Welcome to the FMP Essentials show. I am Dr. Yousef Elyaman, your host, and I am thrilled to have you here with us. Whether you're a seasoned functional medicine practitioner or just starting out on your journey, this show is going to be a go-to resource for mastering functional medicine and making a real impact in your practice and community. Thank you for joining us on the FMP Essentials show.
Disclaimer, the content of this podcast is for educational and entertainment purposes only and is not medical advice. Always consult a licensed healthcare provider before making changes to your health regimen. Views expressed by guests are their own and do not reflect those of the host or producers. No statements about supplements or products are evaluated by the FDA and are not intended to diagnose, treat, or prevent any disease. Listening does not establish a doctor-patient relationship. By continuing, you acknowledge and accept this disclaimer.
Now sit back, relax, and enjoy the show. Hello, everybody. Welcome to the FMP Essentials show. I have a very special topic and a very special guest today, Dr. Lauren Davis. Welcome to the show.
Thank you so much for having me today.
Absolutely. So as we start, as always, we start our show talking about the functional medicine practitioner as a fruit-bearing tree. So what do we mean by functional medicine practitioner? We mean the physician, like Dr. Lauren and I are. We mean the nurse practitioner, the PA, the naturopath, the chiropractor, the health coach, anyone in healthcare that chooses to look at medicine and look at the body from a functional medicine root cause approach. That is a functional medicine practitioner for the purpose of our show. And that's our audience. Plus our audience is also those functional medicine champions, people that are not in healthcare, but they really love functional medicine, and we speak to that level as well. And what we hope is that for the conventional practitioner, they'll be able to see how cool we are and want to be part of the cool club, but also for maybe for the person that is getting some criticism being functional medicine, they can show how evidence-based we are and the way that we approach it. And for people that are looking for careers, or if you have a loved one looking for a career and they like healthcare, we would recommend share these episodes with with them so that they could see what functional medicine is all about. And with that being said, if you look at the functional medicine practitioner as a fruit-bearing tree, you have the trunk of the tree, and the trunk is, you need that strong foundation which holds up and supports everything. And to us, that trunk is going to be knowledge, the knowledge deep dive. And with that, Dr. Lauren, can you give us your 76-second bio?
Sure. So my name is Lauren Davis. I'm an osteopathic physician. I hold 2 board certifications, one in family medicine, the other in osteopathic neuromuscular medicine, so doing hands-on care. I've extensively studied breastfeeding and have been a moderator of the group Dr. Milk, which is physicians interested in lactation knowledge, since 2019. And I'm a breastfeeding mom of 2 with 5 years plus of breastfeeding now.
Nice. So it sounds like for the topic today, you are the right person to talk about it. A physician, yes. And you said you osteopathic neuromuscular.
Correct.
As well. What is that?
So that is a subspecialty of osteopathic medicine, where all DOs are trained to do something called OMT, or osteopathic manual therapy. Those of us who go on to be boarded in osteopathic neuromuscular medicine study it, and study it in all of its types. So just like functional medicine has different aspects that people may end up specializing in, there are different techniques within osteopathic medicine, 10 in total that are tested on the boards, that we have to prove that we are the expert in order to teach other people. So we're the people you see that are at the teaching level in most osteopathic schools to be able to pass on the osteopathic knowledge.
Nice. And for those of you that are not aware of it, you have, as physicians, you have MDs and medical doctor, or DO, doctor of osteopathic medicine. And it seems like they're starting to come together more. Osteopaths, I know doctors of osteopathic medicine can go through the same and do go through the same residency programs that we go through, but also you guys have your own cool special programs. Do you do any osteopathic manipulation in your office?
For mom and baby.
Okay, very nice. So you're staying specialized.
Staying specialized.
All right. So we had so many things that we could have talked about, but you chose this topic, this postpartum depletion. And I don't think I don't think postpartum depletion is even a term that's used in the conventional literature, is it?
It's not. It was something actually coined by a functional medicine physician named Oscar Sarlach, who is out of Australia. And he wrote a book called The Postnatal Depletion Cure. And he's the first one that really identified that there's this syndrome of things that happen to a lot of postpartum women that we attribute to motherhood that are actually related to other things that are happening within their body.
So you could have talked about anything. Why did you choose this topic?
Because I feel like even in the functional world, even after this has come out, and that book was published, I believe, in 2018, we still aren't getting training on it. A lot of times we're afraid of the postpartum period because it includes breastfeeding. And when we have pregnant or breastfeeding women, we sometimes back away and say, oh, maybe I shouldn't do some of these things that will really make a huge difference in these people's lives.
So why do you think I didn't fully understand, why is it that because breastfeeding is involved that people aren't jumping on board? What is it about breastfeeding?
Well, I think that there's something in us that doesn't want to harm a baby, right?
Okay.
And when we don't have a lot of research on what is great for mom, what is great for baby, when it comes to things like nutraceuticals, what can we use, what can't we use for herbals that are going to disrupt that breastfeeding experience? And even though there's a lot of resources out there, we're not taught where to find them. And we're not taught where to go to, what to look up when it comes to these things, like we are, a lot of our other interventions in medicine.
Okay. But this postpartum depletion, this is basically, I mean, it sounds like once a lady has a baby, then there is a depletion of something that can happen. Is that correct? And
That's true.
Nutrients, hormones,
energy levels. There are different areas that we look at that lead to the depletion. So overall, we're talking about low energy states. So what is the reason for that mom to be having low energy? Is it sleep? Is it hormone? Is it thyroid? Until we ask the right questions, it's really hard to tell.
So in a conventional medicine approach, I think there's a lot of maybe attention that's given to the baby, of course, because there's this brand new baby. I'm just thinking of my training. I'm an internist and a pediatrician, and I've been doing primary care since 2006, since I started the practice. And I'm just thinking of where the focus usually is. The focus is usually you just tell the mom, just keep taking your prenatals. Hopefully they got a stronger, better prenatal. You're on the lookout for postpartum depression. And then there's a lot of focus on the baby. Was I just not paying attention, or is there anything more that, from a conventional point of view, they usually do with the mother?
Nope, we're just screening for depression because we know that it affects infant outcomes. And most of that, as you know, is put on the pediatricians in the US.
And I'll tell you what's interesting. So I know that I'm trying to think of how many mothers actually will show up to their primary postpartum. And they do some, but not really that much, not what I'm seeing.
We know that at that 6-week visit, 40% of women will skip it entirely postpartum.
Okay. And who usually, is it the gynecologist or the
obstetrician?
It's
usually the OB that does that appointment.
Okay.
But if we're seeing 40% skip there, how many of that 40% need help or are turning to alternative practices because they're not getting the support that they need from their conventional practitioners?
So let's dive deeper into this postpartum depletions. How do they present? What do they feel? Or are there different categories within it?
There are different categories within it. Overall, they all boil down to low energy. So if we're talking about our mitochondria producing energy, For some reason, they're not charging their battery at night, right? So we're looking at nutrients. What nutrients are needed in that process to make energy?
Okay.
What is needed to rebuild and repair the body after birth? We
Okay.
know that with the placenta present, it's going to prioritize nutrients into baby, and it will deplete mom of her nutrient stores. So what are we looking at for that process? What are we looking at the cost of breastfeeding on the body? We know that protein is needed at higher levels than ever before for breastfeeding women. So in 2022, Brenda Rasmussen and her team at Children's did a study that looked at a mom who was breastfeeding, and they took breastfeeding women into the lab and they actually measured their metabolism. Turns out they need 1.7 to 1.9 grams of protein per kilogram of body weight, as opposed to what we used to think, which was return to baseline at 1 to 1.1. So it's almost double the amount of protein that they need in their diet for just their baseline metabolism.
Okay, and I want to go back to the protein because we're going to talk about how to manage that. So apart from energy, because what is going to make you, first of all, we're going to hope that people will watch this and forward it to people that are expecting, right? Women that are expecting, so that they can prevent this from happening. Is this preventable?
It is.
But what do you think? So we mentioned postpartum depression. I guess two questions. One is, do you think that a lot of postpartum depression is this? And the other question is that what other symptoms will you have besides just you have a baby and then have low energy? Besides that, what else can they expect, or what else could they potentially have?
Yep. So in the brain, that comes out as brain fog, that comes out what we think of as mommy brain, those word finding issues, the difficulty naming objects, the difficulty with stepwise progression of tasks.
Okay.
In the body, it comes out as feeling fatigued, comes out as muscle pains, joint aches. It comes out as just overall feeling like I need to go back to sleep. I just woke up. I feel like I'm not rested at all, or I was up several times last night and I didn't recharge. So that's what moms end up feeling. In the long term, that leads to feelings of anxiety. That leads to hormone disruption. So we can have interrupted cycles. We can have early return of cycles for some women. We can have irregular periods. All of these things come from that depletion.
So how long after having a baby, if a mother chooses to breastfeed, how long, and if she doesn't, how long, what is normal for her to return to having periods?
So usually, if we are not breastfeeding, it's within 4 to 6 months.
Okay.
If we choose to breastfeed, breastfeeding requires a low estrogen state. So we see women with return to their period usually between 9 months and a year once baby starts to wean off of milk full time.
Okay. So you're saying that they potentially could start having periods earlier, or when they have periods, it could be erratic. But I would imagine that if it's 6 months to 9 months before they start having periods in the first place, then I would imagine that they're feeling this postpartum depletion earlier.
They're feeling it earlier.
Okay. And fatigue, joint pain, muscle pain, brain fog, are those the ones that stand out, or what else makes you think, oh man, you have postpartum depletion?
Those are the ones that stand out most to me,
Okay.
especially when it comes to brain performance. That to me says, yeah, we really got to look at what's going on behind the scenes here.
So now let's go into what is actually causing it in the first place. And maybe you mentioned mitochondria, right? You mentioned nutrition, and you mentioned hormones. So is there anything, what categories can we kind of break it down into, and then just kind of dig into one at a time?
Yeah.
When
we're looking at mitochondria across the board, that one and the cell danger response is a big proponent of this.
Okay, so I'll say number one, we'll say mitochondria and cell danger response.
Right.
What else do we have?
We have hormonal disruption, so thyroid, cortisol,
Okay, hormone. And what about sex hormones?
sex hormones, estrogen, progesterone.
Okay, so you have cortisol, you have thyroid, and then you have sex hormones. All right. What other category do we have?
We have sleep and sleep needs.
Kind of like a lack of sleep.
Yep.
Or sleep hygiene, or what would you call that?
Sleep hygiene.
Okay. Okay.
We have our detox pathways.
And then detox. So abnormal detox pathways.
Abnormal detox pathways during the end of pregnancy.
Okay.
And then nutrient depletion that leads to lowered activity of those detox pathways.
Okay, let's start with nutrient depletion, right? So we have, from a nutrient depletion point of view, I would imagine that somebody, hopefully they're taking a prenatal, and because it's going to start before, and what would you say besides the prenatal? What would you say? First of all, is there something that you look for in a prenatal? And if they are taking a prenatal, is there something else that you usually recommend patients take?
Yeah. So if we're looking at nutrient depletion for postpartum depletion, we're looking at the 5 big categories, or the 5 big areas where women don't get enough nutrients. So
Okay.
number 1 is iron. Postpartum bleeding usually leads to blood loss. We usually have low iron storage through pregnancy,
Okay.
and we need to replenish the iron.
Okay.
Magnesium,
Okay.
vitamin K, vitamin D, and iodine.
Okay. So for iron, you can check iron levels, right?
Right.
And then usually the prenatal is going to have iron in it.
The prenatal should have iron in it.
Is it enough?
Usually it's not.
Okay. So you're going to check an iron panel, a ferritin maybe, right?
Correct.
And then if that's what I know, for usually we try to get the ferritin 50 or higher.
Correct.
And sometimes higher just in regular primary care functional medicine. Is that kind of the same thing?
That's the same thing.
Okay.
We also want to see iron stores being replenished.
Yeah, it's interesting. So iron is one of the things you need for cognition and thinking. And you talked about
Yes.
brain fog. So that makes a lot of sense. And a lot of women that, let's say, that are not pregnant, that are having heavy periods, that have brain fog and cognition issues, they should really get their iron checked.
Yes.
So then you also talked about magnesium. Do you check a level? Do you just usually just give them a recommendation for magnesium?
I usually give a recommendation for magnesium. So
Okay.
usually I do nighttime magnesium. It helps with sleep. It helps relax muscles that, all new moms get new mom back, we call it, right? Holding baby, nursing baby in different positions throughout the day. And magnesium, we know that 80% of women of childbearing age are not getting enough in their diet to begin with.
Mm.
So it's a good one to just replenish. And if we need extra, I check an RBC mag to make sure it's getting replenished, but I usually just start giving them magnesium at night.
Yeah, and for our listeners, so magnesium, if you look at magnesium, you need magnesium for life. And if your magnesium levels in the blood go low, you can have a heart arrhythmia. You can actually die from that. And that's why the body is going to give up cellular magnesium, the magnesium in the cells, just to keep us alive. So what ends up happening is that when you check a regular serum magnesium level, the serum magnesium is going to many times be normal, but they're depleted. They have low magnesium. They have all the symptoms of low magnesium because the cells are just giving it all up. And what Dr. Lauren mentioned is she is checking what's called a red blood cell, an RBC magnesium. And an RBC magnesium is looking at how much magnesium are in those blood cells. And that's something you can do just at a standard lab, just many people don't know about it. But you're saying take magnesium regardless, and then you can check the levels to see if you need to increase it a little bit more.
Yeah, especially if we're feeling depleted, chances are that that woman is low in magnesium. So I will start adding that on because it's not very high and it's not in absorbable types in most prenatal vitamins.
Now, vitamin K, it's not one that people talk about often. What's the
It's
deal
not.
with what's the deal with vitamin K, and why postpartum is vitamin K going down?
So we used to think, right? We used to think that breastfeeding did not supply enough vitamin D until we did a study and we saw that giving 6,400 units of D to a breastfeeding mother is sufficient for mom and baby. It's very similar with vitamin K. We give vitamin K at birth, but when we replete vitamin K, we actually see higher levels of vitamin K in breast milk. So vitamin K is very dependent on our diet. When we look at dietary recall, 92% of women are deficient in vitamin K. So I look at vitamin K as that collaborator with vitamin D. And especially if we're talking K2 for absorption, we want to see both of them get repleted so that women have access to both it for their own body and for breast milk sufficiency.
So vitamin K is needed for strength of bones, so it helps with calcium absorption, and it helps I teach on the cardiometabolic module for the Institute for Functional Medicine, and we look at vitamin K because there is an enzyme called matrix GLA protein, and that is vitamin K dependent, and it's found in your bones, and it's also found in the lining of the blood vessel. And its job, if it needs vitamin K to do this, is to pump calcium out of the wall of the blood vessel, which you don't want to kind of get that buildup, and then to pump the calcium, or to pull the calcium into the bone. So if they're vitamin K deficient, they can get osteoporosis and they can get cardiovascular disease. And I know for us, I don't know what you're doing, Dr. Lauren, but for us, the most of our patients are going on a vitamin D and K combo of various doses. Is that?
Yeah.
And then vitamin K. So a thing to think about with these babies is that your vitamin K you get from diet is going to be K1, which is not the form that you can use. And you have to have the right bacteria in your gut to turn it into K2. And babies don't even have the bacteria yet. They have to start growing it from the beginning. And then if the mom has bad gut flora, then by giving them the K2, you're bypassing that. So you give them vitamin K, and then vitamin D you said 6,400, was that the
6,400 units for breastfeeding women every day is sufficient, right? We can do that by sunshine if we have someone, in like warm, sunny Florida maybe, but up here in the Northeast, we don't get that 9 months out of the year. So all of my patients are on a vitamin D supplement.
Yeah. So normally we have the 1,000, 2,000, 5,000.
Correct.
So how do you get the 6,400?
There's 1,400 in the prenatal, and you supplement a 5,000 is how the study was done.
Perfect. Okay. So good. Whew. All right. And then vitamin D is needed for multiple processes as well. And with low vitamin D, there's all kinds of, you can have it's associated with high blood pressure. It's associated with immune issues, with cancer, with so many different things. So it's autoimmunity. So that makes sense. And tell me about iodine. So what's up with iodine and?
Yeah. So postpartum thyroiditis happens in 10 to 15% of women that we detect. It's probably closer to 20 to 25% of women end up with thyroiditis and then Hashimoto's disease because of the leaky gut that happens as a part of this.
Okay.
So what we see is that these women end up having iodine deficiencies from the leaky gut. Iodine is also scoured by the placenta during pregnancy. So iodine stores are low. And we know that iodine is a key component in thyroid hormone. That's going to help set their metabolism. That's going to help with the brain fog, right?
Is there enough in a prenatal, or are you going to give them additional iodine?
There's usually no prenatal iodine.
Oh.
So most prenatals do not have it. So, right, iodized table salt is where we get most of our iodine. But we can do topical things like Luger's solution and other ways to check and make sure we're getting adequate absorption.
Okay. And do you usually just give them a little bit of iodine?
I usually include a trace mineral drop that they can add to water, which includes iodine.
Okay. So you have a trace mineral that has, and I know we have like a multi-mineral that we will sometimes give people. And actually, that's not a bad idea if prenatals don't usually have iodine. I remember reading that selenium is needed. Actually, there was a study in pregnant women. By giving them selenium, it decreased those thyroid antibodies, and it decreased the conversion to like a hyperthyroiditis. But I do know that if we give iodine, if we give kind of the higher doses of iodine, we're always going to be checking their thyroid labs just to make sure that they didn't have that hidden Graves' disease, so that their thyroid doesn't get overactive. So I usually do that in a month. But if you're just giving a multi-mineral, do you usually check the thyroid labs soon after, or do you just say, take this multi-mineral?
Usually I'm checking, especially in women who have had thyroid issues or had hypothyroidism during pregnancy where they needed to be supplemented. That's one of the things that, I see most women after they've had their babies. So that's one of the things I'm checking. Where are their levels at? What are we doing? And how is the thyroid actually functioning based on that?
So let's talk about abnormal detox pathways.
So nutrients are important in our detox pathways. But the other component that most people don't realize is that our sex hormones are processed through the same detox pathways. So our sex hormones, especially estrogen, especially E1, which is the prominent estrogen during pregnancy, rises to be between 100 to 150 times higher than the baseline. Overall, our estrogens rise to 20 to 50 times higher. So pregnancy, we know, is estrogen dominant, but it's estrogen dominant basically on steroids. So as a woman who may have been estrogen dominant before pregnancy goes through pregnancy, we need to drop those hormone levels to get them back down to their baseline, not over weeks, it's actually over days. So after the placenta is delivered, we get this huge drop in estrogen. Those estrogens take up the detox pathways in order to do that. So if we have other things that are competing, if we've had an increase in endocrine disrupting chemicals, if we have low magnesium or low calcium, which are important in those pathways, we're not lowering the estrogen level. So what do we see? We see low milk supply. We see failure of milk to come in. And we know that breastfeeding lowers a woman's long-term risk of chronic diseases and cardiometabolic disease specifically so much. And by not being able to breastfeed, both it's a sign of an estrogen issue and a sign of a hormonal issue, but it's also important for her long-term health.
Okay. So you said estrogen shoots up, but then progesterone, does that go up as well?
Progesterone's also up, and so is cortisol.
Okay, so you have cortisol, the stress hormone, estrogen high, progesterone high. The estrogen is putting a strain on the detox pathways. And then after birth, now that estrogen has to go through the liver. And if you have other toxins floating around, then those toxins kind of get backed up a little bit.
Correct.
So what's the biggest way you support it?
Fixing the gut.
Okay.
So during pregnancy, during the third trimester, what we see is that a woman's cells in her gut lining open up. And at any other time, we would call that leaky gut syndrome, right? But they open to actually allow passage of the microbes into the lymphatic channels. And there's a pathway called endomammary translocation, where those bacteria are then moved into the breast. And we're starting to study this for breast cancer. We haven't looked at it as much from a functional perspective and how this pathway actually disrupts the gut. So 100% of pregnant women in their last trimester will have leaky gut syndrome. Now, when we look at the research, when it comes to children, when it comes to antibodies in breast milk, 50% of women will still pass full-size protein into the breast milk to cause allergic reactions in their kids between 3 and 6 months of age. So what that tells me as a functional practitioner is that 50% of women aren't closing the leaky gut, and they're not closing those borders, the brush border. So they're still getting protein absorption and full-size proteins 3 to 6 months out from having a baby.
No, that makes a lot of sense. And me being an internist and a pediatrician, the pediatrician side will see these women that their kids are not, or their babies are not tolerating their milk, and we'll have them go on a dairy-free kind of food plan. And what you're saying is that they get this increased intestinal permeability. Yet all women end up getting it at the end of the pregnancy, to
Right.
where the intestinal cells are supposed to be tight together, and they don't let large particles in the bloodstream. That now this opens up, large particles go in, and that and now that stays opened up, and by keeping it opened up, now their dairy and other large particles may leak in and go into the breast milk. Now, let me ask you, what is advantage of having bacteria make its way into the breasts what is the survival mechanism? Why is that a positive thing?
So it allows our baby to get our microbiome. So we talk about seeding through the vaginal canal, but breast milk is basically repeated exposures to our microbiome to help seed their gut even faster. So we know that breast milk prevents complications like NEC. We know that breast milk for infants helps heal their own gut, because it's essentially, if we're thinking of it as a practitioner, it's like giving IgG, right? It's like giving Interrogam or one of the other supplements to help close the brush border. We're doing that for our babies naturally.
All right,
And we're seeding them with the right bacteria.
Dr. Lauren, so you're telling me that by breastfeeding, they're actually giving good bacteria to the baby in the breast milk?
Correct. Yes.
So for those of you at home, if your minds have blown, like mine has, but it's like it blows like in the back of my head, that's pretty good. I think we can end this talk right now. I think this is the pearl. But no, we'll keep going. So that's pretty cool. That's interesting. I did not know that. And now I do, but it's so amazing how everything works. So it's actually, so another reason for breastfeeding is that you're actually giving a probiotic to your baby.
Correct.
And how long are you supposed to be seeding? Because you don't want to fully heal that leaky gut if you're supposed to be allowing it in.
Right. So there's a balance that happens as we transition to full milk. We will seal the breast blood barrier somewhere between 4 and 6 weeks after delivery. So
Okay.
4 and 6 weeks is where we see healing of all of the borders, but that's also where we start to see that infants will react to different proteins that are still present in the milk. Between that 4 and 6 week mark is the most common time to diagnose issues like milk protein intolerance, where we assign dairy-free diets, or reflux that's worsening as that supply comes to its full amount.
Which if the mother doesn't have the right kind of bacteria in her gut, then she could be seeding that to the baby as well?
She can, but the body is kind of an amazing thing, because throughout pregnancy, that high estrogen level is also selecting out certain bacteria. So during the first trimester, we see an overall increase just in numbers, right? We're talking our counts go way high at first, and then we narrow down our selections. And we narrow down the selection into things that are most beneficial for baby when our gut is functioning properly. So we'll see that moms end up with higher levels of lactobacillus in their gut that'll then translate to their breast milk. And sometimes we wonder how things like Klebsiella can sometimes get into a baby's gut. Well, it's because it's passing into breast milk. We can actually see it in cultures.
Okay. And is that a bad thing?
It's not necessarily a bad thing because we're just seeing what's there in the breast.
Okay. Okay. So now you support the gut. How are you supporting the gut?
So first, we're looking at what is irritating mom's gut, right? We're basically working on healing up the breast barrier. So there are a few different things when we talk about what's safe in breastfeeding moms. Marshmallow root is a great one. Slippery elm is safe in breastfeeding moms. We can do IgG or colostrum supplementation, which helps. We can do glutathione, which are all safe for breastfeeding women.
Okay. And so colostrum, you said, what was the other one? You said, was it glutamine or glutathione?
Glutamine.
So you glutamine, which actually we use to help with healing leaky gut.
Yes.
And then probiotics.
Probiotic foods. I prefer.
Foods. Okay. So you work on their gut. And are you working on their gut before they conceive?
We try, right?
Okay.
But it depends on where someone is finding me in their journey. I receive a lot of women who are coming to me for breastfeeding issues. So usually I'm getting them in the postpartum period, but I would love to see that happen.
So this whole concept of leaky gut, I know it gets a lot of people throw the word around, but I'm not sure if they understand what's actually happening. I think they just say leaky gut and it's kind of a buzz term. And then some people will judge you because you use the term. And then some people will say, oh yeah, leaky gut. I saw it on social media, right? So, and they believe in it. But for those of you that are conventional and already like, oh God, leaky gut. No, leaky gut is a thing. It's increased intestinal permeability. And it just means that the cells that are lining the intestine are leaking. They're opening up and they're allowing large particles that normally don't come in or leak in. It allows them to get into the bloodstream. I would imagine that by doing that, it could actually improve the mother's immunity as well. But the problem is that when people are perpetually in that state of this increased intestinal permeability or leaky gut, it actually leads to autoimmunity and all kinds of other issues. And I think now what I'm going to do is if somebody has really bad leaky gut, I'm going to tell the patient, man, your leaky gut is like that of a pregnant woman. Do you think that would work? Maybe I'll get them scared with the...
Well, then you might have to go on to explain what you mean by that, but...
That's fine. I have no problem with that. Because you see, pregnant women have really leaky guts. Like basically what I'm saying is that you're kind of like pregnant. All right. So we talked about the gut and helping those detox pathways by helping the gut. We talked about nutrients. Let's talk about hormone disruption.
Mm-hmm.
Cortisol first. What's going on with?
So we know that during pregnancy, cortisol is being made by the placenta. So cortisol will continue to peak up until delivery and that placenta is gone. If we have any birth trauma, if we have tears of the perineum, if we have irritation, even if we have psychological issues like our delivery didn't go the way we wanted, we can continue to trigger cortisol activation. But we have to understand that it's also in the setting of an overall downregulation. So after that placenta leaves, cortisol's reached about 3 to 4 times its baseline while we are pregnant. Going through postpartum, we get that cortisol drop that we see similar to adrenal fatigue. So we see women who are coming in with this abrupt change in cortisol, that we're having stress hormone activation then because we're trying to replete what we became dependent upon during pregnancy. So if we have someone who's already at risk with adrenals that aren't producing enough cortisol, we've basically shut them down a bit during pregnancy because the placenta has taken over and has been releasing cortisol. Now we see this cycle where the placenta is gone And the amount of cortisol we have to keep making, right? Placenta's releasing a cortisol releasing hormone, but it's also releasing some of the cortisol. So it takes that burden a bit away from the adrenals.
Okay.
So now we need someone to reactivate their adrenal glands and come back up to their normal rate to deal with the postpartum period and the normal stressors that are there, like sleep disruption cycles. So if we have women who have already reached that level of fatigue in the adrenals, we then see depletion on top of it.
Mm. So they have adrenal fatigue, meaning that kind of like a lower cortisol state due to chronic stress.
Correct.
And they're usually we see their salivary cortisol levels low, and then they get pregnant, and now the placenta starts making the cortisol. And if the placenta is making the cortisol, is this why some women feel much better when they're pregnant? Because some women
say why women feel better, right? For women who are progesterone dominant, a lot of times they'll feel better because they're moving into estrogen dominance during pregnancy, and they have higher cortisol activation.
Right.
All of a sudden we get to postpartum when we need those adrenals to function at their full effect, and we don't have that.
Right. And cortisol is a steroid, and it's a corticosteroid like something like prednisone.
Yes.
And anybody that went to the doctor with joint pain and got a steroid pack, a lot of times they can tell, whoa, I feel so much better. I feel more awake. I don't even need to sleep. And my pain is better, but you can't stay on it long term because it has negative effects. So in a way, it sounds like pregnancy is a way of getting that steroid hit. And then
Yes.
and then if they were not, now their adrenals already were kind of shut off due to stress. And now but then they don't have to, because the placenta is making it, the adrenals don't really have to make it as much, and they already couldn't make it, and then now all of a sudden the placenta leaves. So I would be like, just keep the placenta
like having
in
your
me.
support buddy just leave you, right?
Yeah, don't leave. Can we keep the placenta in? Is that a possibility?
Then we don't make breast milk.
Okay, fine. Okay, so then that you say goodbye to the placenta, and then they tank. And I know for me in clinical practice, what I've noticed is that a lot of people that have this resistant depression really just have this suppressed cortisol, and that's playing the role. They feel tired, they feel weak, they're draggy, they don't have that drive, and then we diagnose them with depression. So that does make sense that that's a piece of the postpartum depression, where in functional medicine, we know multiple imbalances could lead to one disease, and then you can have multiple diseases caused by one imbalance. So it's kind of back and forth. So what do? Do you check cortisol testing in these women?
I usually do salivary cortisol testing to see where they are.
Only if they're tired?
No.
Or everyone?
I check almost everyone across the board.
Okay.
Because they're still getting sleep disruption.
What if their cortisol is low? Then what?
Well, then we're looking at how we can help support it, right? We're replenishing nutrients. We're looking at what those precursors are that we can help support. We're looking at DHEA balance to cortisol ratio to see if they're imbalanced. We're looking at the upstream levels. So we're looking at things like pregnenolone, and we're looking at cholesterol levels to make sure that they're getting in adequate intake.
Okay.
So that they can feel well.
But then do you ever give them cortisol?
Do I ever give cortisol?
Yeah. Do you give hydrocortisone to them? Hydrocortisone.
I usually don't when they are breastfeeding.
Okay.
I will sometimes supplement pregnenolone or progesterone if their estrogen is really dominant, because that will also help move into the cortisol pathway.
Because the placenta makes a lot of progesterone and cortisol,
it does.
Right? And then how does the body get the extra estrogen? Is it the placenta as well?
The placenta makes E1 predominantly.
Okay.
So normally cycling women have a predominance of E2.
Okay.
But placenta will usually support with predominantly E1. It makes all three of the estrogens.
Right. And E1 is the one that when I see E1 in a non-pregnant person, when I see that high, I think we got to get your detox pathways going.
Correct.
Okay. All right. Interesting. So what about, we talked about cortisol. What about thyroid?
So thyroid, right? We're looking at thyroid levels to see how that's supportive of the rest of the body, right? Thyroid, we think about really setting our metabolism. And lactation is a full body metabolic change. So in order to support the breastfeeding body, we use still about 10 to 15% more thyroid hormone than we would have at our baseline if we decided not to breastfeed. So even that 10%, 10 to 15% bump, sometimes with women who don't have the precursors there, who are low on selenium, iodine, all of their nutrients, that bump is hard for them to keep up with. Not to mention, we add on leaky gut. So now we have the ability to make thyroid antibodies, just like we have the ability to disrupt the blood-brain barrier and then have all of the mental fatigue and consequences there.
So towards the end of pregnancy and the beginning of postpartum in that leaky gut phase, if somebody has an underlying autoimmune condition, probably not during pregnancy because they have all that cortisol, right?
And they're immune suppressed, right?
Yeah, so they're immune suppressed.
Knocked down their immune system.
But now I would think that if they did have cortisol problems before pregnancy, and then after pregnancy they have the leaky gut, and then now their cortisol drops. Now it's like that perfect storm for autoimmunity. And You're saying that this is the time where they can get autoimmune thyroiditis, right?
Right. And we typically see thyroiditis as one of the more predominant autoimmune conditions for women in this time, but really we can see anything. And we know that over 50% of pregnancy complications happen in the postpartum period.
Okay.
And part of it is the autoimmune activation.
So what do you do about it?
We go back to fix the issue, right? We look at the gut, we fix the gut. We make sure the detox pathways are working well so that we can rebalance the hormones. We replenish the nutrients that we need to make all of our hormones. And we support the body as we need it. We look at whatever we're finding and we help the body to the best of our ability as practitioners.
Right. But you're limited by nursing, right? There are certain things that you wouldn't give that you may give otherwise. Like would you put, if you saw somebody had thyroid antibodies shoot up, would you put them on a gluten-free diet? Would you what is your go-to when you see those antibodies up?
So I usually eliminate dairy and gluten
First.
if I'm seeing a lot of autoimmune symptoms. If I'm seeing those numbers change, I'm still doing it for a breastfeeding mom. There's no reason she can't get all of her nutrients from a whole foods-based diet.
Right. You don't need gluten or dairy to survive, right?
Correct.
So that makes sense. And the nice thing about that is, I know it can be frustrating going on these restrictive food plans, but if you cut out gluten and dairy, if you're not feeling well, those thyroid antibodies are shooting up. And if you get somebody to take the if you get somebody to go off of gluten and dairy, you could check in a month and see if those antibodies are going back down again. You can tell that there's an improvement happening. So it's not like just, hey, stay on this forever. It can be a trial and error thing, correct?
Especially when we catch it early, right? We're not looking at it downstream 3 or 4 years where this has been going on. But if we can catch this in the postpartum period, we can intervene and we can stop the process from happening, I think.
And then sex hormones. So do we have anything else with thyroid that you want to share?
I think those are the biggest pearls.
All right. And actually, before sex hormones, this goes back to, it might be related, but you and I spoke a little bit offline that there was a video that was circulating basically saying that women's bones deplete when they're nursing, and they were kind of endorsing giving them a certain amount of calcium. That's something that you wrote a book, right, on this topic?
I did.
What's your book called?
It's called Thrive Mama, the Ultimate Postpartum Blueprint.
Awesome. So this is something you're very passionate about and something that you're researching. You're actively researching. What's the deal with that? What's the deal with bones getting thinner by nursing? Does that mean stop nursing?
It doesn't mean stop nursing.
What? Okay.
So what we see is that women who are nursing actually have a parathyroid hormone protein that's made that goes to the bone to release more calcium. And we do that intentionally because our baby needs such high levels of calcium. We want to keep calcium levels stable in the bloodstream. So what ends up happening is that we get some bone loss that's known to reverse within 18 months to 2 years after we're done breastfeeding.
Okay.
The issue becomes when we have cycles of pregnancy and breastfeeding that happen back to back to back, where we're not giving the bones time to regenerate. We can see earlier onset osteopenia. However, that process given 5 years will reverse itself when we get adequate nutrient intake. So that means that we're getting enough calcium from our diet or we're supplementing it. We haven't actually proven yet that if we give calcium to breastfeeding women, it limits the amount of bone loss that they have because it's a hormone-driven process.
Yeah, that makes sense. I know back to kind of the primary care, non-postpartum medicine, one of the things that we were told for years is that you really want to increase your calcium to decrease osteoporosis or thinning of bones. And there was actually there was a population study they looked at, and of course there's lots of flaws with these analyses, but what they saw is that people that consume the most amount of dairy had the highest amount of osteoporosis. And we don't know why that is. Like there's theoretically, it could be that, and why do I say dairy is because usually conventional wise, the first thing they tell you to start taking is increase your dairy, right? If to increase your calcium. So one of the theories is that because the dairy has calcium, but it's more acidic, then the body, in order to buffer that acid, it releases it from the bones. And that maybe dairy isn't the best way to get your calcium. The other thing is that they found that if they gave calcium supplementations to people, that they had a higher risk of calcifying their blood vessels. So maybe the bone might have helped the bone a little, but it might have also helped worsened the blood vessels. And then that kind of brings us to the vitamins that are needed for calcium metabolism that people are many times deficient in. So many people are vitamin D deficient, as you said, because they're not getting enough sun. Even if you have sun, you need a certain amount of skin exposure for a certain amount of time. You can't be wearing sunscreen. So you need vitamin D to absorb calcium. You need magnesium, the mineral, to absorb calcium. And a lot of people are magnesium deficient. And then you need vitamin K and you need activated vitamin K. And maybe giving a whole bunch of calcium isn't really the way to go. And what I usually do when I have patients with osteoporosis or osteopenia is I have them try to get as much of the calcium recommendation as they can out of foods, out of leafy green foods. That's kind of the way I go. Sometimes we'll supplement a little bit, but we make sure they have the K and D. And I'd imagine with your plan, because you're focusing on the need of vitamin K and magnesium and vitamin D, all of those things, just what I know about the human body, things are always changing, right? That sounds like that would really support a woman's bones. But that also, you mentioned a point too, that maybe spread them out every couple of years, instead of having a baby every year.
Yes.
Okay. I mean, you do what you got to do. Sometimes you have a short window and you got to knock them out, and within 5 years you'll be okay doing the other stuff. But I'll tell you, the other thing that I'm liking, or that this opens up my eyes to, is how dynamic bones are and how amazing the human body is. It's not just your bones are a certain thickness and you just lose bone till you retire. It's no, the bone, you can actually deplete a bunch of bone when you have after having a baby, and then you can bring it all back. Now, is that bone depletion is only for women that are nursing?
That is only for women who are nursing.
Right, because it has to take it to make all of that calcium.
Yeah,
Um,
they don't
do-
know for sure, but they think it's related to the high prolactin levels that turns on that pathway.
Makes sense. But do you recommend any calcium to postpartum
I
women?
definitely recommend calcium. Calcium,
Okay.
especially for women with PMDD,
Mhm.
when they're coming up on their cycle, sometimes it's exaggerated when they're nursing because those
Okay.
hormone drops are so big. And
What,
calcium and magnesium can help with that.
what's PMDD,
Premenstrual dysphoric disorder.
and what do they feel? How do they know they have it?
So they are going to experience mood swings, irritability, low mood, or anxiety for about 5 to 7 days before their period.
Eh,
And because breastfeeding, we have high prolactin and oxytocin levels, sometimes that hits a little bit harder for these women. And they
Okay.
get something called DMER, which is dysphoric milk ejection reflex, where when they go to nurse their baby, they actually get intrusive thoughts and they get anxiety that worsens around the time of nursing, especially in neurodivergent people, because of the way that we have to make prolactin.
And what are neurodivergent people?
So people with autism, ADHD, bipolar disorder, schizophrenia, all falls into the neurodiversity spectrum.
Right. With the implication that it's not abnormal, there's just different
It's just
variations,
different brain type.
different brain types. Right. So back to so what can they do about that?
So sometimes in conventional medicine, we will give them a serotonin inhibitor to take
Okay.
a week up before their period.
Okay.
The other option we can do is magnesium and vitamin D have actually been shown to help with that pathway. Or I'm sorry, magnesium and calcium. Taking it for a week before the period has been shown to help with PMDD symptoms. So that's another approach for women who don't want to take conventional medicines.
So I've had patients with PMDD that do really well when you give them progesterone. Is that
It has
something
to
that,
do with the hormonal imbalance. Sometimes you can get away with that with breastfeeding.
okay.
Some women will be so sensitive to the hormone cycle for
Mhm.
breastfeeding that can lower their milk supply. We talk about progesterone not having a lot of interference in breastfeeding, but sometimes it can, even if we give it for birth control.
So would so progesterone, are you talking about bioidentical progesterone that you just get the prescription,
So that is my go-to,
yeah,
but a lot of times, right, people will want to take what's easy and convenient at the pharmacy.
the birth control
So
pill, you're saying?
progestins,
Progestins.
as
Okay,
in,
yes, because they're
right, as in progesterone only oral contraceptive pill.
yeah.
And those can interfere with breastfeeding women.
And
with their milk supply.
progestins are different than yeah. So no, that makes sense. Progestins are not the same as progesterone. They're
Correct.
And you could get. Do you ever write for? Because you can get a prescription, conventional medicine prescription at the pharmacy, no compound, just for micronized progesterone, which is what the body has, versus the progestins that are kind of these chemical structures that are similar but not the same. So do you ever give progesterone?
I don't as much.
Okay.
I tend to compound, and if I'm adding, I'm looking at their whole hormonal picture. So sometimes there will be other hormones that I add into that prescription, and I find it's easier to compound into one.
So are you usually doing it like as a cream?
I do topical cream. Yeah.
Okay. So what's a typical prescription look like? Progesterone and what else?
Progesterone plus or minus estrogen and or testosterone, depending
Okay.
on what their whole picture looks like for those steroidogenic hormones.
And you'll sometimes do that postpartum.
I will sometimes
well-
do that postpartum.
While they're nursing. Okay, good. So let's go on to then let's talk about we talked about progesterone, right? Let's talk about the estrogen and the testosterone. in
Sure.
this phase?
So when we are depleted, when we are not feeling well, the body tends, we talk about the cortisol steal, right? The body tends to have higher cortisol, meaning that we will have imbalances in the sex hormone side of our pathway. So we will have testosterone gets converted to estrogen. Estrogen gets converted, right? We have E1, E2, E3 that are all lead to the detox. So when we see predominance of E1, which is what we have in pregnancy, we sometimes block up those detox pathways. That can get backed up so that you have higher levels of testosterone then, because the body is naturally trying to lower the estrogen levels postpartum.
Okay.
But also the reverse happens as we continue to breastfeed. As we've gotten 4, 6, 8 months into our breastfeeding journey, we've now lowered our estrogen levels to where they need to be to support long-term lactation. It also comes with decreased testosterone. And testosterone for women is really tied into libido and sex drive. That also tends to come with the postpartum period. So if a woman is having low libido, if they're having vaginal dryness, testosterone in their compound can help improve those symptoms for them.
Now, a lot of times I will give, if their testosterone's low, my first step is going to be giving DHEA because it can become testosterone. Can you give DHEA in that postpartum?
You can.
Okay. And then sometimes you just make a cream and you give them what kind of what they're missing.
Right.
Yeah. Is it vaginal or topical or both?
I do topical.
Topical. Okay. And how long do you put them on these hormones?
Usually it's a short period to get them through their depletion, right?
Okay.
Normally, once the body is getting all of the nutrient building blocks back, once they're getting more sleep towards that, 8-month to 1 year mark, usually we're seeing improvement across the board in the hormones, but not always. So I support them until their bodies are naturally recovering.
Okay. So you work on balancing their hormones. And then last but not least, mitochondria. So mitochondria are those little cell looking things within our cells. They are very, very efficient at taking oxygen and taking nutrients and creating all kinds of ATP, which is our main energy source. And if your mitochondria are damaged and they're not doing well, then you go into what's called anaerobic metabolism. So you get this backup of you have such a huge decrease in ATP, and you get lactic acid that goes up, and which now you're talking about low energy, and you're also talking about potential pain with lactic acid. So take it from there. Tell us about mitochondria and postpartum.
Sure. So when we're thinking about mitochondria, we're thinking about stress, right? The cell danger response is a response in our body to a low energy state. So it can be high cortisol levels, which happen naturally during pregnancy. It can be physiologic stressors on our body, like going 12 to 24 hours without food while we're in labor. All of these things can trigger the cell danger response. I like to think of it as our body's way of trying to reserve our energy sources, right? So if we are going through this period, if we have the cell danger response that gets triggered, what happens is that we need to get through those triggers. We need to basically say to the body, hey, it's safe again, and turn off that signaling pathway. What needs to happen in order for that to be the case is we need to have balanced hormones. We need to have cortisol that's down. And we know that process after birth takes at least a week to normalize out. We see a huge dip. It's a curve, right? We see a huge dip in the first 3 to 4 days, and then normalization back toward our pre-pregnancy state. But if there's shifts in the gut microbiome, if there's other things that have happened, we then see that cell danger response can be triggered for longer. And that is basically keeping us in a low energy state. We're not going through our primary cycle. We're not getting all of the ATP generated that we need. we're basically going into the other pathways for our mitochondria to be able to function. But they will never function as well in an anaerobic pathway as they will in the aerobic pathway, right?
So is there any testing you do?
Depends on where we are in the process. Usually I try to get women to break that cycle with meditation, with safety signals to their body.
So you're saying that if you feel unsafe, if you have chronic stress, then that will translate to the mitochondria being dysfunctional. We know it'll translate to the hormones being off.
Correct.
And you're saying you get them meditating, you that work on stress management to improve their mitochondrial health. And the stuff that you mentioned from a nutrient point of view will help.
It will.
I mean, you need it for mitochondria. Is there any other supplements that you may use if you're thinking that, man, this person has some mitochondrial dysfunction?
I will use different supplements, but part of my goal is to teach a mom how to regulate at her baseline without having to depend on the supplements, right? So if we are constantly triggered by stress, if we were triggered during the delivery, or if we are staying in that state postpartum, there are also great ways to change the physiology of our body with natural interventions. So if we look at Amy Cuddy's research, she's a neuroscientist, and she looks at the body posture and what changes in our hormones. We know that if we hold a victory pose for 2 minutes, we will see a 45% boost in our testosterone.
Can you show us a victory pose?
And so it's arms above head, standing tall, and holding that for 2 whole minutes.
Okay. And that will
have a 45% boost in testosterone for the next 20 to 30 minutes, right?
Right.
But teaching women how to deal with the stressors of motherhood, especially early, is going to change their trajectory for long term and change how they deal with stress as a mom. Because what I find is a lot of women who are getting into the postpartum period are finding that they weren't prepared with skills that they need for time management, that they need for every other part of their life. And that's causing them stress. So if we then equip them with skills to get over any challenge, we're also helping to manage their mitochondria and their energy production.
Right.
Because if we take away all of the stressors, right? If we take away a lot of the cortisol activation, we improve their long-term health and mentality.
So it just sounds like this is a perfect storm. Having a baby, if you want everything to shut down, just have a baby and nurse.
And I think that's why we see so many traditions that have this built-in period where moms are supposed to be supported and centered.
Makes sense.
Right? If we look at Mexican culture, there's a 40-day period where women come back to live in their mother's house and basically be cared for and their infant be cared for by their immediate family until they're feeling recovered, which usually takes a month.
Yeah, amazing. And we're like, go back to work. When can you come back to work? Like, no. So I think, I forgot to ask for hormones. Are you for the sex hormones? Because we know you can check the thyroid. You do a saliva cortisol. Are you checking their hormone levels? Are you checking their estradiol, their testosterone, their maybe dihydrotestosterone? So you check that.
I usually do a Dutch test.
Okay,
so usually
that's a more
some sort of
urine,
dried urine hormone testing.
But then again, with that, like, do we have established postpartum levels? Because I'd imagine
we don't.
Okay, so you kind of have to. You're kind of figuring it out.
We don't have established pregnancy levels either for us to really reference, right? With those tests.
Well, you know what's. I think that's the challenge. You know, vitamin D. I remember reading a while ago that vitamin D, the vitamin D level that we check in the blood, the 25-OH vitamin D, the storage form, that actually has to be activated in the kidney to become 125-OH vitamin D, and the active form is the one that works, right? And that in pregnancy, we don't check the 125, we just check the 25-OH. And in pregnancy, your conversion to the active form of vitamin D, the 125-OH vitamin D goes so high that you could probably test 125-OH vitamin D as a pregnancy test. So what do you even do with that? And all the D you give them is shunting. So it's kind of, before they even get pregnant, you got to establish a dose and I think leave it alone. And the same thing. So then if you don't have established numbers with this Dutch test, which is not something that insurance covers.
Right.
So if you don't have established numbers, what are you going by?
So I'm going by my experience
Okay.
and the thought process that a breastfeeding woman by 4 to 6 weeks postpartum should be returning toward her baseline.
Okay.
With the idea in mind that she was just in a very, very high estrogen state, especially E1.
Okay.
So if I'm seeing E1 pathway dysregulation, that needs to be addressed more than anything else for her to establish a full milk supply and to have, I think of low milk supply as part of the postpartum depletion because of everything that happens to disrupt that pathway. So that's what I'm seeing a lot of my patients for initially. And that's what I'm looking at, is to see exactly what is going on in those pathways, where we can support them with nutrients, and what needs to happen in order for their body to come back to their baseline state.
Okay. For a cycling woman, if you look at the first 14 days, her hormones are going to be different than the last 14 days.
Mm-hmm.
So first you're going to have estrogen go up and progesterone go down, and then it flips, and then estrogen goes down and progesterone goes up. And if they're, after a month, if they're not cycling, what number, what are you referencing it to? Are you referencing it to the first 14 days, the last 14 days, or you just kind of have your own number?
I'm looking at day 21. I'm looking where they would be coming down
On day 21.
because that's closer to the balance for postpartum.
And
So
that's
for
higher
breastfeeding,
progesterone.
That's higher progesterone, lower estrogen.
Lower estrogen. And then for that, that being said, if you're looking at it being more like day 21, then if you look at that range, a lot of that makes sense that you could check the progesterone, and the progesterone may be leading people to this depression if the progesterone's low.
Yep.
Okay, that makes sense. Cool. Very good. Well, that was an amazing interview. Thank you so much for that. And now it's time to spill those functional medicine organic beans. Let's go over the stuff that you can't learn on AI, your clinical experience share.
To unlock additional premium content, including the deeper dive in this clinical topic, leadership and speaking tips, charting and efficiency pearls, and business mastery as a functional medicine practitioner champion, be sure to check out our mastermind and other membership programs at www.fmpessentials.com. Hey everyone, we hope you're enjoying the FMP Essentials show so far. Pretty amazing, isn't it? Remember, if you're part of our mastermind, don't miss out on our exclusive bonus clinical content. That's where we take a deeper dive look at personal experiences and real-world insights that you can't just get from a book or from looking on AI. It's where we really get into the nuances that make a difference in your practice, the experience of the guest of our show. Thank you for watching, and we hope you enjoy the rest of the show.
Making an impact. So back to the tree analogy. So if a functional medicine practitioner is a fruit-bearing tree, the fruit has seeds, and those seeds can be planted. And how can they be planted? They can be, for us, they're planted through mentorship and through community involvement and giving back. And really, as the functional medicine practitioner, what we want is for them all to have some sort of a legacy and to give back to others. So before we wrap up and go into this section, what exciting areas or projects, what are you working on that you're excited about right now?
So right now, I am working on a mentorship program for people who want to learn more about how I do functional medicine in the postpartum period.
Okay.
Still in the works. Who knows when it will be done? But that is one of the pipeline things that I would love to share with other practitioners.
Okay, so you're going to do a training. It's kind of like a training in postpartum.
Yeah.
Okay, awesome, awesome. So with your marketing skills, which we talked about kind of in the internal one, I think you will be able to get that message across. Good luck with that. And you have a book as well, right? Your book
I do.
What's your
Is
book?
Thrive Mama, the Ultimate Postpartum Blueprint.
Can you say it one more time?
Thrive Mama, the
Uh-huh.
Ultimate Postpartum Blueprint.
And how do they find that book?
So far, women are loving it. It is written for patients so that they can really understand how the things are affecting them. And what I tried to do in that is incorporate questions at the end of each chapter so that they could really go back and assess their own level of depletion.
So great feedback on it. Where can they purchase it?
It's on Amazon, Barnes & Noble, Apple Books, most of the big sellers.
Awesome. Awesome. So what are some impactful ways that practitioners can contribute to their communities?
So I always think giving back is one of them. Finding something that is mission adjacent in your community or in the larger community, and finding a way to help support their mission and support your own mission.
Can you give me an example?
Sure. So for physicians, the Centers for Fourth Trimester Care, C4TC, is a physician-led organization focusing on supporting postpartum women. So
Okay.
it's doctors who either do in-home care for postpartum or have practices that are specialized around the fourth trimester.
And can you share any personal experiences or initiatives that you've been involved in that really make a difference?
Yeah, so one of the big ones I like to support is Postpartum Support International, PSI, which is
Okay.
big on mental health. They do a lot of free programs and have a free helpline for any woman who is experiencing postpartum psychosis, depression, and hook them up with a practitioner near them and help pay for those resources. So that is always one that I am supporting.
Are you supporting it like financially
Yeah.
financially? Okay. Are there any other organizations that you believe we should be donating to as functional medicine practitioners?
So those are the two big ones that come to mind. Always
Okay.
there's anyone that's trying to spread the message for functional medicine. And
Yeah. And I know the Institute for Functional Medicine is a non-for-profit, and they
yes,
do a lot of that. You can donate there. And we also, environmental work group,
right.
that's something that I'm passionate about. I feel like they're doing a huge job. Awesome. Well, if you take a look at really the most valuable thing we have, it's our time, and you've been extremely generous with your time. Thank you so much for your patience and your knowledge. I'm sure this is going to help a lot of people, and hopefully it's going to help women that are in that often not really paid attention or looked at when it comes to their health, like after the baby, because everything becomes about the baby from what I've seen. But also it'll hopefully it will help inspire conventional practitioners to become functional medicine practitioners, or at least open their mind a little bit. As you guys see, this is science we're talking about, right? This is we're looking at evidence and research, and hopefully it'll inspire others to get a career in functional medicine. So with that being said, how do people stay in touch with you?
Yeah. So on Instagram is probably the easiest place to find me at Dr. Lauren Davis DO.
Awesome. Well, thank you for sharing and ways of giving back and sharing your information, and hope to see you soon. Take care. Hey everyone, I'm Dr. Yousef Elyaman. We hope you enjoyed the show. For more exclusive content from this interview, check out our FMP Essentials Mastermind. Make sure you check out our website at www.fmpessentials.com for our blog and other content. If you enjoyed this show, please, please, please subscribe, Give us a like. It helps way more than you could imagine. Thank you for watching. Follow us across all social media platforms at FMP Essentials HQ. Please don't forget to share this with your practitioner friends, and we'll see you in the next episode.